Thank you, Sophie. And thank you to the Move charity for asking me to come and talk today about the late effects of breast cancer treatment. So we know that there's many cancer treatments out there for breast cancer. And, these include surgery, chemotherapy, hormonal therapy, biological therapies such as immunotherapies, and also radiotherapy. And what I'm going to really concentrate on today is the radiotherapy late effects and the chemotherapy late effects. But what we really have to remember is that many patients will go through many of these treatments or a combination of. And we also know that those patients who have more than one treatment for breast cancer usually have a higher symptom burden, so more side effects to deal with, and then potentially are at risk of more late effects. But my expertise really is in the radiotherapy and the chemotherapy side of things. So the first thing I want to say is that everything I'm going to talk about today, none of it is meant to frighten anybody, and people are not guaranteed to get any of these late effects. Many patients will have their breast cancer treatment and live a very full, long, healthy life with no problems whatsoever. So it's really important just to get that across. But we also know that living a life with a history of cancer is unique for every person. Many people will have minor late effects, which will affect them, not very much on a day-to-day basis, but others will have major that are very difficult to live with. And we know that life is different after cancer, and that many patients will have an ongoing physical and emotional challenges that they'll experience daily for the rest of their lives. We also know that cancer and its treatment can often leave a grueling physical and mental legacy for many, many years after. And that was some work that was done by Macmillan in 2013. So what is a late effect then? Well, a late effect is a side effect. So something that you experience usually when you're on treatment that doesn't settle, or a symptom that develops after 6 months to many, many years after treatment completion. They can be often difficult to diagnose, especially if it's an effect that starts maybe 10 years after you finish your radiotherapy treatment. And we also know that it is really, really well recognised that treatment side effects, especially those from radiotherapy, can be difficult to diagnose, and management can be complex. And we also know that more damage can be done to these tissues that were in the radiotherapy treatment field by inappropriate investigations and treatment. So what about the scale of the problem then? Well, Macmillan did some work and they have found out that there's currently 3 million people living with cancer in the UK, and that's going to rise to 3.5 million by 2025. And we also know that's going to be over 4 million patients living with these side effects by 2030. So you can see how we're surviving so much more from cancer, but actually the patients living with these later effects is going to keep growing. We also know that 1 in 4 cancer survivors will have one or more treatment-related consequences which will affect their quality of life. Some research that was done in 2010, and this was symptoms that were reported 3 to 5 years post breast cancer treatment. They reported that 50% had persistent pain, 15 to 25% were experiencing lymphedema, and 35% had a restriction of their movement in arm and shoulder. So the evidence that was done back in 2013, Macmillan, and this really was the basis that we kind of set our late effects service up on, really. And they found that 78% of the patients that they surveyed had a physical health problem in the last 12 months that was directly related to their treatment. And this next statistic just absolutely blew me away, that 71% of those patients who'd finished treatment 10 years ago or more had experienced a physical health problem in the last 12 months that was directly related to their treatment. It found that 40% were living with emotional problems and hadn't sought any help, and that 40% of patients actually said they were unaware of any long-term side effects. Now, what I will say is that I think we've really come on over the past 10 years or so in really telling patients about the late effects of treatment. And the Royal College of Radiologists have done some great work around site-specific consent forms that really go into the detail and the level of risk about late effects. So I think we're certainly better than we used to be. But what we also know is that often patients, when diagnosed with a cancer treatment, actually don't really weigh up the risks, because actually just they want to be cured. So we also need to be very aware of this as well. So in terms of radiotherapy, which I'm going to talk about first, this really is the treatment that keeps on giving. And that's because of something called radiation-induced fibrosis. So this is something, it's a progressive fibrotic sclerosis with varying clinical symptoms. And basically radiotherapy affects all the tissues that were in that radiotherapy field. So any tissues in there can be affected. So that's such as skin, the connective tissues, muscles, nerves and blood vessels. And because it affects where we treated, it can then affect that normal body functioning by causing hardening, tightening and restriction of tissues and muscles. It's lifelong once you've usually got it, and it can be a progressive disorder. But what again I want to stress is that not everybody will experience this and will experience varying levels of it if they do get it. This just to show you some pictures then of what radiation fibrosis can look like and some of the real common late effects that we see, particularly in our clinic. And the first one is this radiation-induced fibrosis. And you can see this by the pictures that I've put on there. So you can see that in the picture that's labelled A and B, you can see there that one of the breasts there has contracted due to this fibrosis and changed in shape. You can see that we've got changes in the skin texture and also what we call radiation dermatitis, which is because this fibrosis caused this, what we call this telangiectasis, collection of breakage of blood vessels on the skin that you can see there. So these skin changes can be quite common along with the radiation-induced fibrosis. And the fibrosis, as it presents, again, we'll have these varying clinical symptoms. For some patients, they may just find the breast tissue feels a bit harder, there may be a bit more discomfort. But for some patients, it can be this real change in how the breast looks. It can shrink and feel quite hard, that it causes quite a lot of pain, and then it can start to restrict movement with the arm. We also know that patients who've had radiotherapy, and particularly those who've had surgery and certainly axillary node clearances, are at a much greater risk of lymphedema. And we're not just talking about lymphedema in the arm. We see a lot of patients who have this lymphedema of the breast tissue and the chest wall. And often it's not always really significant. So it can just be quite a minimal amount of fluid collection, but to a patient that can feel really uncomfortable. Pain is the most common symptom that patients get referred to our service. And often we find that this is a lot because pain usually starts when patients have that surgery. They're diagnosed with the cancer, they have their surgery. So our receptors in our brain that help to turn up and down our pain levels tell us that pain actually in that area needs to be something that we need to worry about. Then we have the radiotherapy that causes all this inflammation. And if we have some of this fibrosis as well, months, years down the line, you can see how our pain receptors in our body tell us that we really need to be worried about this and turn up how we feel about this pain. So we need to work a lot with our patients on trying to turn these receptors down. Also teaching patients how to breathe again, because often when patients have had surgery, they kind of go like, scrunch up a bit and kind of forget how to open up their chest cavities and breathe really, and that can really be really potential for patients for trying to decrease those pain levels. If you can get them to breathe what we call abdominal deep breathing, turn down those pain receptors and work on some other bits to really try and turn those pain levels down. We also know that a lot of patients can have altered shoulder and arm function. This might be due to fibrosis, it may be due to lymphedema, it may be due to the surgery that they had and the scar tissue that can build up there. So they're the main top things that we tend to see in our late effects clinic. So some of the less common radiotherapy late effects, and if I'm honest, some of these I've never seen. So these really are not to be frightened about. But obviously, if you're one of them patients who's got it, it's really significant to you. So the first one is nerve damage that the radiotherapy has caused. And this tends to be because the fibrosis is starting to press on some of the nerves. A long time ago, we actually did a lot of over-treatment with the radiotherapy. It doesn't happen now. So we did get patients who got what we call brachial plexus nerve damage. That's the nerves that are here under the shoulder. And we cause quite a lot of pain and discomfort and loss of arm function because of that. But like I say, the radiotherapy is planned so well now that this doesn't happen. And actually, I will say that for the majority of these, such as the lung fibrosis, the cardiacs, the heart issues, all of these things now, the radiotherapy is planned to such minute detail, and we have certain techniques. So a breath hold technique. So patients who are having their left side treated will hold their breath while the treatment is delivered to move the heart and the lung out of the way as much as possible. So we really do plan the treatment so that patients do not experience these late effects anymore. And like I say, there's a handful that I've seen over the years of patients, and we certainly don't get referrals for that anymore. So that is something to be aware of. But we do know that these still can happen, and some patients who maybe were treated 10, 15, 20 years ago may be referred for us for this. So with lung fibrosis, that's because the radiotherapy again causes damage to the lung tissue, and it can cause some breathlessness and some discomfort in that area. Morphea is another really rare skin condition, which is it presents as like small, like purple kind of nodules and white nodules within the treatment area. And the skin can be really, really hard and pearlized. So we need to work on breaking that. And again, all down to this fibrosis. The cardiac issues, like I say, and what I want to say about the cardiac issues is that when your treatment is planned, if they felt that you were at risk of any cardiac toxicity, then you would be put onto remote monitoring for this. So that's ECGs on an annual basis. So it's something that you can discuss with your consultant if you wanted to. So if you was at risk, they would have spoken to you about this. Necrotic ulcers. So this is where the skin actually breaks down and often never heals because of this fibrosis and the necroticness of the tissues that can occur. Rib and collarbone fractures, because the damage that we actually do to the bones that are in the treatment field. Again, these can be quite painful for patients to experience, but they often heal quite well, if I'm honest. Osteoradionecrosis, where the bone actually becomes necrotic and in some cases becomes exposed, so the skin can die away and the bone can become exposed. I have never seen this within the breast with a patient who's had breast cancer treatment, and looking at the data, it was really, really minimal. The same for costochondritis. This is where we get painful joints, really. So the muscle that's between the ribs and the breastbone can get really quite inflamed. Again, it's something like less than 0.1% of overall patients that experience this, but it is still a late effect treatment that a potential breast patient could experience. And then there's always the risk with radiotherapy, because it is ionizing radiation, that there's a possibility of secondary cancer. And that's at something like 10 to 20 years out of treatment. But again, the risk is less than 1%. So moving on to chemotherapy then, as we know, chemotherapy, so radiotherapy is your really localized treatment. So we only affect the area that we're treating. Whereas your chemotherapy agents, these affect from head to toe. And when you have your chemotherapy, they tell you that obviously different chemotherapies affect different systems within the body more. But this is just a lovely little pitch that I like to show, to really show you that basically it's a systemic approach, and you can have head to toe issues really from your chemotherapy. But what do we commonly see? So for breast patients then, and I've put gastrointestinal problems on here. So this is when it affects your gastrointestinal tract. So people can suffer with lots of indigestion and heartburn, but also it can affect your bowels as well, causing problems that, although if I'm honest, I have never seen a breast patient who's actually experienced that. What we tend to really see again is this pain. So it's often painful joints that patients experience, but more often than not, it's this peripheral neuropathy. So this is the tingling of the hands and feet that patients can sometimes experience, or patients explain it as feeling like they've got cotton wool hands and cotton wool under the feet. So they never quite get the perception right when they're walking, or they can't hold pans, make a cup of tea, or even get themselves dressed in the morning. They have real difficulty with that. So that's something that we do experience. Fatigue is one from chemotherapy that patients particularly tend to talk about, and of course we have our menopausal symptoms. And it's not just about the hot flushes. We need to remember about the vaginal dryness, which is really common and very rarely picked up, and actually very rarely discussed. So it's really important that we're thinking about all those things when we think about the menopause and menopausal symptoms that patients can experience from the chemotherapy, and of course from hormonal therapies. And we know that with patients who've had chemotherapy, we can experience this called chemo brain. And it really is this like loss of cognitive function, memory. They can't remember things. They start a sentence and halfway through forget what they're saying, forget to turn lights off. And for some patients, particularly if they may have some pain, say from peripheral neuropathy, and they're also fatigued, you can see why all these things cluster together and make each and every symptom worse that they're experiencing. The less commonly seen late effects from chemotherapy are fertility issues. Again, cardiovascular disease, so these problems with some of the anthracyclines that we give for chemotherapy, and osteoporosis. So again, like I say, we very rarely get any of these referred to our service, but it is something that we need to be aware of. The other thing we need to just think about, and I just realised I've missed a slide out here, so unless I'm in a different order, no, I don't think I am. So there was, sorry, I had another slide that was talking about really about the, we need to not be aware it's not just the physical effects that patients experience. There's effects that patients experience due to the psychological problems that they're experiencing, the psychosexual side of it. So the fact how it might be due to vaginal dryness, or the fact of body image concerns. All these then things start to affect us, how we feel as a person, but also can affect our relationships. So it's really important that we think about that when we're starting to see our patients. And that's certainly something that we do in clinic. We really sit down with the patient and try and get that whole holistic approach. So really about what matters to the patient, what matters to you at the moment, what problems you're experiencing, and what can we do. We often have to look at the vocational side of it. So how are these late effects that you're experiencing affecting your day-to-day living? Are you managing to get back to work? Are your hot flushes so bad that you're not getting up, you're awake most of the night, so you can't manage to do your work during the day? It's really important that we are looking at all of these. So it's not just about the physical effects that we're experiencing. So I just wanted to have a little talk now about living with late effects. It's fantastic if you've got access to a late effects service, but I appreciate that many people who are on this call tonight will not have access to a late effects service. So I'm going to do some signposting at the end. So I wanted to give some tips really on living with late effects. And the first one is to make sure that you are moisturising your skin well. So that's the skin within the treatment area and where you've had any surgery as well. If you've certainly got any lymphedema in the arm as well, it's a good idea to make sure that you moisturise that arm as well, because we know that the more hydrated your skin is, the more supple and flexible it is, the more chance you've got of being able to break down any fibrotic tissue, for any fluid to move around, and to keep the whole area much more supple. Keeping mobile is really important. Obviously, some exercise is great, or movement. I know we don't like to call it exercise, but movement, you know, I'm talking about for your whole general well-being there, so such as what the Move charity does. But in particular, we're talking about these finer flexibility, range of motion exercises that we need to do to keep the whole area moving where you've had your radiotherapy and any possible surgery. Physiotherapists may have given you some exercises, and I know certain radiotherapy departments sometimes give some dedicated exercise, arm and shoulder movement exercises as well. But for those patients who maybe don't have access to that, there's the Cancer Rehab PT that you can find online. She's on Instagram as well, and she's a physiotherapist. I think she's in New Zealand or Australia, but she has some fantastic exercises for patients who've had breast surgery and breast radiotherapy to really try and open up that chest cavity and keep those shoulders and arm movements moving. And also the Lymphedema Support Network has a range on there as well that you can have a look at. But I'm a real big believer that if we can keep ourselves moving and really do these small range of motion movements that we need to do, that we can increase flexibility and also possibly break down those fibrotic bonds that are trying to break up, develop from the radiotherapy. We also need to be really sure that we're wearing a well-fitting bra. So I'm going to move on to the next slide about that. Staying hydrated is really important, and also a balanced diet to try and maintain a healthy weight. We know that patients who are more overweight are usually more sedentary, so they tend to sit around more. And we know that anybody who's got any lymphedema or any kind of edema, it will always be worse, as will pain, as will fatigue, as with all of these side effects, if we're sedentary and we're not moving about much. I'd say if you've got any signs of edema, so it's not just about, you know, swelling of the hands and the arm. If you think, gosh, when I take my bra off or I remove my prosthesis and I've got a real indentation, is there possibly some fluid there? It doesn't have to be what we call pitting edema, which is where you press it and you get that indentation. If you feel you've got any signs of edema there, it needs to be checked out. And that's because the earlier that we can identify and manage lymphedema, the more controllable it is. It's a really good idea to try and do some mindfulness and some relaxed breathing, because again, this can reduce our pain levels, but also it can really help to open up that chest cavity and really start to help with that flexibility as well. If you are finding that you are exceptionally tired, if you've got any of this peripheral neuropathy, it may be worth trying to get your GP to do some routine bloods, because we know that if you're deficient in certain vitamin D, vitamin B, some of them things, it can mean that you can get some supplements for that, and they can sometimes help. There is some evidence around that. So what I want to do now is just move on to living with pain, really, because like I said, this is the main the main thing that most people experience, in my view, the referrals that we see to our clinic. So how do you live with pain if you've not got access to services or a specialist pain service? So the first thing that we found is actually using a hot and cold compress on the area can be really useful. Again, this firm bra. If you are exercising, make sure that you're wearing a well-fitting sports bra. Again, maintaining a healthy weight. We know that patients that are overweight will have higher pain. The relaxation therapy to help relax and that. There is some studies out there that have said that limiting or eliminating caffeine altogether can really help with breast pain in particular. And again, patients who have a high fat diet can tend to have higher levels of pain. Movement and the abdominal breathing, like I've said, but also consider using an over-the-counter pain relief. So whatever you might normally take, but we also know that, and yeah, I must just say, please check with your nurse specialist or your GP or your treating team before taking any new medication or supplements, because obviously during this conversation I can't be assessing every person that I'm speaking to. But actually some ibuprofen gel can be really helpful, rubbed on the chest wall or the breast area to try and help with that pain. There's also some evidence around evening primrose oil, but again, make sure you can take this, especially if you've got a hormone receptive cancer, and again, get your vitamin D levels checked, because patients who take higher supplements of this, again, there's been studies out there that have shown that it can reduce the pain. So I just wanted to move on to bra and prosthesis tips, and this is because a lot of the patients who come to our service, they're never wearing the right bras. It's very difficult. So they take their bras off and they've got all indentations where the bra straps were, they're not wearing them right, they've got pain, and sometimes all we do is give an explanation, get them a better fitting, or teach them about a better fitting bra, some relaxation, and we're getting rid of their pain for them. It can be that powerful. So just some tips then, really. So first is to check your straps. So you should be able to get 2 fingers under the strap at the shoulder, okay? Wider straps give better support. Now, I know wider straps usually mean they're the more older-fashioned looking bras, but even if you could just wear this bra like majority of the time during the day, and then when you're going out and you want to feel, more attractive or a nicer looking bra because you might be able to see it through your top, then you could go to your narrower fitting ones. Fuller cups will give more support. And obviously a sports style will give that more compression. So if you are finding that you're getting a bit of edema within the breast, then some compression might really help within that. If when you put your bra on and you have a look in the mirror, you can see that the cup puckers around the nipple area, that means your cup is too small. Okay. Similarly, if the band rides up at the back, that means that the band width is too small for you. So you need to get measured for that. You can also purchase some gel pads that go underneath the straps for comfort, and this might be particularly helpful if you're wearing a prosthesis, because some of them can be quite heavy. And if you can, and you've got lymphedema, try and choose a prosthesis that's lighter in weight. So where can you find help then? Well, the first thing I want to say is, like I say, if anything feels different and doesn't feel right to you, then get some help or report it to somebody. Don't think it's something that you just have to put up with. So the first thing I do is try and see if you've got any local late effects services in your area. Obviously, if you're in Nottingham, so that's Nottingham City, Nottinghamshire County Council, had your treatment at Nottingham, even if you live now in London or Scotland, you can be seen in our late effects service. And we do a lot of this remotely via video, and that's the email, but I'm sorry, we can't obviously see patients that are out of area or didn't have treatment with us. But there are so many late effects services setting up and down the country now. So what you can do is, I would say, is contact where you had your treatment, contact the radiotherapy department and say, have you got a local late effects service? And you might be quite surprised at what you find there. Maggie's centres can be really quite helpful if you're lucky enough to have one of them in yours areas. They do a lot around fatigue management now, menopause clinics, they have support groups. We've certainly got support groups for late effects patients now within them, so they really can be a great source of help. Try your GP, particularly if you think, do you know what, I've got really shoulders not great, so they can refer to physiotherapists for you. They don't have to be a specialist in cancer treatment. And certainly if you feel that you are struggling with swelling, they can refer direct to a lymphedema service for you. You don't need to go back through your cancer team. The other thing I say as well is GPs can refer to menopause clinics. Most hospitals have these now, so it might be worth asking your GP for a referral to a menopause clinic if you're really struggling with menopausal symptoms. There's also a number of psychosexual services out there to try and help with that, any sexual function or relationship issues that you might be having. So just finally then, some helpful websites then that may be of use to you. So of course, Macmillan Cancer Support covers every cancer site, and they do have signposting on there, and they do have information about late effects and lymphedema and fatigue and that kind of thing. Breast Cancer Now is a site that can be quite helpful again, specifically for breast cancer and Cancer Research UK. I put Trexstock on there. Now, of course, this is, if you do know this, for patients that were treated in their 20s and 30s, but they are really good around fatigue management, that coaching and goal setting, and certainly around menopause support. But it's something that you might want to have a look into there. The Cancer Rehab PT, like I said, has some amazing YouTube videos and Instagrams on there that you can have a look at. Lymphedema Support Network is particularly for patients and professionals. But again, you might just find that, that you might not feel that you've got lymphedema, but they've got some arm exercises on there and some relaxation tips on there.